Hi, I'm Dr. Sridhar Kalyanasundaram. In this video, I intend to cover 2 or 3 topics or questions that the parents often ask. One of them is about the BCG reaction. As we all know, the BCG vaccine is given to protect the baby against future risk of tuberculosis, and it's a routine vaccination in most of the developing countries. In the developed world, it may be given routinely in some countries, or it may be given in a targeted group. And recently there has been interest in the BCG vaccine again due to the possible protection against the coronavirus, which is not established firmly yet. So the BCG vaccine is a live vaccine. It has an attenuated or altered form of the tuberculosis bacteria, which is the Bacillus calmette-guerin, BCG. And the same strain has been used for many years now. The injection is given into the skin layers. It's an intradermal injection, so technically it's a difficult one, and it's typically given in the left upper arm, which is the deltoid region. This is in terms of convention important to remember, because the one of the ways we assess if the vaccine has been given is to see the scar at the site of reaction, and if you have a uniform site where it is given, it's more easily detected. There are often questions about whether the BCG vaccine can be given in a different site, but we don't recommend that, because the effectiveness of the vaccine depends on its uptake by the body, the bacteria multiplying locally, and our immune system reacting to it, and the skin thickness and various factors may play a role in that. So better to follow the convention, because that is the most widely studied in terms of effectiveness. The typical reaction to the BCG vaccine is a slight raised area at the site of injection soon after it, because it's an intradermal injection. This also confirms that the injection has been effectively given. This may not happen all the time, and it may subside quickly before the baby comes to you after the nurse gives the vaccine as well. The reaction starts around 3 to 4 weeks in most cases. Sometimes it takes up to 2 months, and there is a slight bleb formation, and it blisters. The size of the blister varies from baby to baby. In some babies it's small, some babies it's large. The blister breaks eventually, and fluid comes out which is clear. You just have to clean it and keep the area clean. No need to use antibiotic powders or creams. Some babies it closes and it breaks off, so the sealing and breaking process may take 2-3 rotations, and the full healing may take sometimes 3 to 4 months. There are occasional babies where we don't see the BCG reaction, so that puts us in a dilemma whether the vaccine was delivered correctly or whether the baby didn't react for any reason. So before we re-administer the BCG vaccine, we have to make sure that the baby has immunity against it or not, because if the baby is already developed immunity, the second injection may lead to more side effects. You may get local lymphadenitis under the axilla or in the upper neck, or you may get an exaggerated ulcerated form over the BCG mark as well. So we consider doing a tuberculin test, which is an intradermal test for whether the vaccine is taken effect or not, and if the reaction is negative, you can safely proceed with repeating the BCG vaccine. So many parents often ask us about the swelling that comes up, and they don't know that this reaction is expected for the BCG vaccine. So all that it needs is educating them, and sometimes it also helps to inform them at the time of giving the vaccine itself. The next point I would like to discuss now is about the stool pattern in babies. Does my baby have a normal stool pattern? Is the baby constipated? So constipation by itself is defined as hard stool, which is difficult to pass, and the frequency may be delayed because it's hard to pass. In a breastfed baby, it's almost never seen. Typical constipation is not seen, but stooling frequency is very variable. In the same baby, it can vary a lot between weeks, and it also varies after a certain period of time, or when you make changes in either the mother's diet or the baby's diet, or you change your location and so on. if the baby has a treatment with antibiotics for any reason, that may change the stool pattern. So in the newborn period, in the first week or so, the baby typically passes small frequent stools. The thick meconium in the first 2 to 3 days changes to transitional stools, and then the typical yellow mustardy or CD stools comes up. Gas formation and passing gas with a little stool mixed with it is normal as well. After the first 3 to 4 weeks, some babies go into the slow mode when they may not pass stool for a few days in a row. So up to 5 to 6 days is often seen, and as long as the baby is comfortable, the tummy is not very distended, and the baby typically passes soft stool when the stool is passed, even if after a few days, it's a normal pattern, so there is no need to be worried. Some parents are worried, and we may try tickling the perianal area with the Vaseline soap bud after 3 to 4 days of time, and that stimulation may make the baby strain and pass the stool. After 6 days or so, you may consider using a glycerin chip or a suppository, but it's not necessary. If the baby typically shows the same pattern again and again, you can wait. Changes in the mother's diet, maternal antibiotic use, and introducing other foods to the baby changes the pattern. So don't be worried if the pattern changes over a period of time. And if the baby is formula fed or mixed feeding, the stool pattern may be affected by that as well. And if you are giving the comfort milk or the hydrolyzed milks, for example, you may get grayish stools, which is normal. And if you see excessive irritability, baby has some mucoid stools on a repeated basis, especially if there is mucus strings or blood in the stools, it may suggest milk protein intolerance, and you have to discuss with your pediatrician. So the third point is for a parent to be aware as to when they should take the baby to a pediatrician or neonatologist in the first few weeks of life. So obviously the first 2 to 3 months is taken as a critical period when we should be a little more cautious, a little more aggressive in terms of seeking medical attention. This is because any condition can deteriorate rapidly, and it may lead to a life-threatening situation. Talking about this, I would like you to refer to my video on postnatal problem management, where I have talked about the sudden infant death risk factors. You should be aware of taking those precautions. The next important thing is about watching the infant life support videos again, so just be familiar with those as well. In general terms, if the baby is feeding well, gaining well, and gaining weight well, and you have had the initial follow-up review typically 3 to 4 days after the initial discharge, you would have known that feeding is going well, the jaundice is improving. So usually the pediatrician or neonatologist gives you the advice as to when the next follow-up should be, and if everything goes well, you can stick with that pattern. Many parents are worried about colic, which typically starts after 2 to 3 weeks, and typically it's a self-resolving problem over 2 to 3 months. So some degree of tolerance and patience is important. It's important to look at the feeding pattern, encourage the sleep pattern of the baby, and not to overfeed. So don't be tempted into feeding more and more just because the baby keeps crying more and more. So sensible parenting involves holding back as well at times, and always carrying the baby, cuddling the baby may not be best thing to do in these situations, as a baby may get habituated to that as well. Feeding patterns can be set by waiting longer between feeds, and remember that overfeeding is often driven by parental anxiety. We may misread the baby's cues as hunger cues, and obviously get the baby trained to feed every time baby cries. So this can lead to obesity in the future as well, and it can aggravate colic and lead to reflux in the process. So we should understand this part. Stooling pattern we just discussed. Most of the time we don't need to worry about constipation in a breastfed baby. If in a formula feeding baby there is hard stool on a repeated basis, or you see blood streaks in the stool, you do need to consult. If there is any bleeding manifestation, skin bruising, any such manifestation, you need to consult. Nasal congestion is often a minor problem. Some sneezing and nasal congestion can be resolved with just saline drops. Slight increase in body temperature in the evenings is normal. The head is always a bit warmer compared to the rest of the body, because the brain is vascular and it's growing rapidly, so the metabolic rate in the upper part of the body is more. Jaundice, obviously, if you feel worried that it could have increased, suddenly the baby looks deeper yellow, you need to review earlier than planned. If the baby still appears to be jaundiced after 2 to 3 weeks of age, it may be prolonged jaundice, and we may need to do a liver function study to make sure the baby does not have a conjugated type of jaundice, which may need more intervention or investigations. If the baby is not feeding well, has poor activity, has fast breathing persistently, or doesn't look well in general terms, is very quiet, doesn't respond to your handling like normal, these are serious signs that something may be wrong. Some babies get paronychia, which is infection around the nail bed, especially if you have tried to trim too close to the nail bed, and better to show the pediatrician in these instances. When the nappy rash is too severe and doesn't respond to the barrier cream alone, you may need to show. So use your common sense, don't panic. Obviously, in general terms, if the baby is feeding well, is reacting normally, it's not an emergency. You can message your pediatrician if you have access to their email, and check with them if it's important. But if you feel baby is looking poorly, has fever, any fever in the first 2 to 3 months, we do recommend you to check with the pediatrician. You can, if it is borderline high like 38 degrees or so, you can recheck after you ventilate the room better, make the room a little cooler. But if it's persistently high, you do need to check, and obviously it's better to be safe than sorry. With this, I will close this video, and I hope it's helpful. If any questions or comments, you can put in the comment section in the video. Thank you.